ちょっと1時間ぐらい静かにして。
Dear friends and colleagues, I would like to welcome you today on behalf of the Scientific Organizing Committee to the second day of our IFSO MENAC virtual meeting. I would like to say that a few days ago, the bariatric community lost one of the giants of bariatric surgery, a scholar and a mentor to us all, Dr. Scopinaro. May his soul rest in peace. This year, we would like to introduce this new session. It's called the Top Paper Session. The main aim of this session is to introduce and recognize surgeons from our IFSO MENAC region who have contributed to our bariatric literature. In this session, the authors are going to present their work, and then a discussant, who's a member of our scientific committee, is going to critique the study. Finally, the moderators and the audience will be able to ask questions directly to the authors of these published papers. The audience will vote and choose the best paper of this session. The winner of this best paper will get a free IFSO membership for the year 2021. At the beginning, let me introduce myself. I'm Ashraf Haddad, and I would like to introduce my co-moderator. I'm sure he doesn't need any introductions, as all of you know him. Dr. Kasama, he's the director of the Weight Loss and Metabolic Surgery Center at UTSUYA. He's also a clinical professor of Oita University, and he's actually the president of IFSO APC chapter. And Dr. Kasama.
Thank you, Dr. Haddad. It's really my honor to be invited as a moderator of this great session. And I would like to introduce two great papers in this session. And after two papers, we have discussion regarding these two papers. The first paper is, the title of the first lecture is Serpine 1G methylation and protein as molecular predictor of laparoscopic gastric outcome. The speaker is Dr. Abdelbaki, and the discussant, Dr. Handa. And the second paper is conventional versus distal laparoscopic one anastomosis gastric bypass, a randomized control trial with 1 year follow-up. The speaker is Dr. Nabili, and the discussant is Dr. Kelala. And the first speaker is Dr. Abdurabaki from, he's an associate professor of surgery of General University, Alexandria University, Faculty of Medicine, Alexandria, Egypt. And the second speaker is Dr. Nabili from Egypt. He is a consultant of bariatric surgery of the Faculty of Medicine, Beni Suef University, Beni Suef, Egypt. So that we would like to start the two great presentations. So please start the first presentation.
It is my pleasure and a privilege today to speak to you about how to critically review a paper. I would have loved to be there in person, but I guess with the COVID, a virtual talk is what we can do. This is my disclosure slide. It has no bearing on the presentation. I think this summarizes what I'm going to talk about today, is that the only way to get manuscript research writing is to practice, to just keep doing it until you get good at it. I'm going to talk to you today about a review of a paper from the Annals of Surgery, how to write a manuscript, and then cover statistics for a little bit. So this is a paper looking at laparoscopic repair of very large hiatus hernia with sutures versus absorbable mesh. Versus non-absorbable mesh. This is a study from Australia, published in the Annals of Surgery. So the introduction should be short, and it should be to the point. You should have a sentence that explains the background about the topic, You should have an explanation of what's lacking in the literature and what you're trying to fill, as well as your research question and your hypothesis. But the shorter the introduction, the better. So for instance, this is an example of the study we were just talking about. And you can see they have a clear objective to compare suture versus biologic versus synthetic mesh. And they're trying to look at recurrence. And they clearly define why is that important based on the previous published literature and the fact that most of the trials looked at short-term recurrence in their explanation. The method section is important to all be in present tense, and it's basically a cookbook style. So if someone would to read your methods, they could replicate your study. Should have no results, should describe the statistical methods, inclusion and exclusion criteria, and describe your study sample. And you should not make the common error of listing how many number of cases were included in your study. That goes in the results. Describe only the study period and explain your methodology and how did you do your statistical analysis, and did you use mean and standard deviation versus median and interquartile range, and again, if there's any IRB information or consent. And you should explain in detail the operative technique that was done, as well as preoperative and postoperative workup and follow-up respectively. So as you can see in the study, there's a clear hypothesis, clear design, and their primary outcomes are outlined in a prospective double-blind trial. You can see they specifically outline 4 centers, 9 surgeons. They have a clear definition of what's a very large hiatal hernia and clear description of what exactly they're trying to do in terms of the 3 different techniques, how the randomization was done, what was the preoperative workup, that the surgeons exchanged videos of the standard operative technique, that they did not do a callus gastroplasty, how were the short gastrics dealt with, how was the esophagus encircled, and so forth. And then post-operatively, what was the choice of care, and intraoperatively, what was the choice of fundoplication. Now let's look at statistics. Some of the important things in statistics is to understand what is the null hypothesis. And a lot of us get very bogged down with statistics, but you need to inform yourself about the basics. So the null hypothesis says that there's no difference between the 2 treatment arms. That suture repair versus mesh versus biologic mesh should make no difference. So type 1 error is when you say that there is a difference, and in reality there is no difference. So you reject the null hypothesis falsely. A type 2 error is when you say there's no difference, but actually there is a difference, but maybe your sample size was not big enough. And I think this picture explains type 1 and 2 errors best. So type 1 error is when you tell a man they're pregnant, and type 2 error is when you tell a pregnant woman she's not. So you need to also look at how is your data represented. Is your data normally distributed or not? And if it is, then the mean equals the median equals the mode. And your data should be presented as mean rather, plus or minus standard deviation. But remember, 95% represents 19 out of 20. And when you present data that's normally distributed, it means that the 95% of the data falls within 2 standard deviation of the mean. So if I say patient's age in the study was 45 plus 6.5 years, it means 95% of the patients are between 32 and 58. And if data is skewed to the right or skewed to the left, you should use median and interquartile range to represent your data. So again, if you see the example here, this is normally distributed, so the mean equals the median equals the mode, and within 2 standard deviation from the mean represents 95% of the data presented, which gives us the p-value of less than 0.05. So it's important when you look at the data to compare statistical significance versus clinical significance when you interpret your data in your study. And sometimes you might need to use odds ratio and confidence interval, and it shows the data graphically easier. But let's say if you say the odds ratio of something is 0.67 and the confidence interval, whether it crosses the 1.0 line or not, can tell you how statistically significant or not the outcome is. So let's look at, for instance, this example, and let's take, for instance, for this matter, mortality in a certain group of patients. So the dot is the odds ratio, the line is the confidence interval, and this is the 1.0 line. So as long as you cross it, your data is not significant. If you stay within one side of it, then your data is statistically significant. Then let's go to the results section. What's important about the results section is to make sure that you don't repeat the data in the tables and that you don't explain your results. You only present your results without explanation. Then you talk about your discussion. It has to run like a story, it has to be clear, and you have to start the first paragraph with your most important findings. Then you compare them to the published literature in the following paragraph, and then finally state the limitation of the study. You have to explain your figures and tables and explain why your study is important or not, and don't overstate your study. Say it exactly how it is. Focus on the sentence structure. Make sure your sentences are short, clear, and direct. Talk about one thing at a time. Don't use phrases interchangeably. Don't say procedures and surgery. Use one of them. Each paragraph should tell a story or an organized idea. The whole manuscript or discussion should tell a story. Use transition phrases in a smart way to link things together by saying similarly or in addition, or separate them by saying in contrast, and so forth. Then start the discussion with your most important finding. Always start the paragraph with a subject tense sentence, like saying the gut is made out of 3 parts. Then I'm going to talk to you about the foregut, midgut, and hindgut. Always start the sentence rather with the subject to make the sentence clearer. You can see those 2 examples. Which one is clearer depending on how you start the sentence with the subject or not. When you come to your conclusion, it needs to confirm your data, not overstate it. Make sure you don't have type 1 or type 2 errors. And your manuscript needs to be clear, without repetition, runs like a story, short introduction, methods in present tense without results, results without interpretation, and discussion to the point, including your limitations. To give an example here, the outcome of our trial have shown no significant difference for the assessed primary outcome, recurrent hernia at the hiatus by radiology or endoscopy. And then the rate of recurrence measuring 2 cm was low across all groups. And they can tell you the results of this trial do not add support to the routine use of mesh. Short, to the point, and it represents what they have found in their study. So what should you do finally when you receive a manuscript that was rejected? It is the cheapest way to get professional advice. Examine it objectively. Was the journal suitable? Were the reviewers fair? And you need to know that no one is after you. Reviewers are trying to improve your manuscript. Resubmit only after you've addressed all the reviewers' concerns, line by line. Highlight your changes, or try another journal or ask for help from a colleague. And research is a team sport. Make sure you have a list of collaborators. The bigger the list, the better things will be. Again, I want to thank you for the chance to present to you today, and I look forward to seeing you in the future in person. Thank you very much.
Good evening, Chairman. I would like to thank IFSO Organizing Committee, IFSO MENAC Organizing Committee, for inviting me to present my research, which is a project on epigenetics and bariatric surgery with the title of SERPIN1 gene methylation and protein as a molecular predictor of laparoscopic sleeve gastrectomy. This project, to the best of our knowledge, is the largest study with the longest follow-up to date on the impact of bariatric surgery on epigenetics. This is my case mix. So recently there has been an increasing number of studies exploring epigenetics and its correlation to obesity. However, research is still limited on the impact of bariatric surgery on epigenetic regulation. So the question remains, can we use special biomarkers to predict responders after bariatric surgery? That's why we looked at SERPIN1 protein and SERPIN1 gene methylation as potential biomarkers. SERPIN1 is also known as plasminogen activator inhibitor, which is a glycoprotein encoded on chromosome number 7, which is under normal condition produced by the hepatocytes, platelets, and adipocytes. And as you all know, obviously it's involved in hemostasis. Under pathological conditions, it can be produced by inflammatory cells, and this is through a cytokine-induced overexpression. When we look at obesity, several studies have demonstrated a correlation between BMI and SERPIN1 protein levels. However, the exact mechanism is still not clear. And recently, SERPIN1 protein has been suggested as an independent risk factor for insulin resistance and as a predictor for the development of type 2 diabetes mellitus. Interestingly, modulation of SERPIN1 protein levels were reported by several studies after different weight loss interventions. Therefore, it would be interesting to test the potential predictive power of such a marker to the success of weight loss after bariatric surgery. When you look at epigenetics, epigenetic changes may include alteration in DNA methylation, chromosome modification, etc. These reversible alterations modulate the accessibility, of those transcriptional machinery, therefore affecting the gene expression and its product. And obesity has been interrelated to changes in DNA methylation patterns, and specifically SERPIN1 gene methylation has been correlated to obesity, metabolic syndrome, and weight loss after simple dietary restriction. So again, it would be interesting to investigate the role of SERPIN1 gene methylation as a potential predictor for weight loss and improvement of comorbidities after bariatric surgery. So in our project, we aim to evaluate the relation between preoperative plasma level of SERPIN1 protein and its gene methylation to weight loss and improvement in inflammatory state and insulin resistance after sleeve gastrectomy. We followed our patient for 2 years. So we included 100 patients, 50 patients underwent sleeve gastrectomy by a single surgeon at the university hospital setting, and we compared that to a control group of average weight patients. At baseline, we recorded basic demographics, routine labs, anthropometric measurements. We measured the CRP levels, the HOMA-IR. We did genomic DNA sequencing to determine the degree of methylation. We did the plasma level of SERPIN1 protein level enzymes. And then at 6 months, we followed our patients, anthropometric measurement. Again, we did the CRP, the HOMA-IR, the methylation levels, the plasma levels of the SERPIN1. However, at 1 and 2 years, we only followed the patient for anthropometric measurements only. And as you can see, throughout the follow-up, along the 2-year follow-up, there was significant drop in body weight, significant increase in total weight loss, percentage weight loss, with improvement in the waist circumference ratio. Then comes those charts where we evaluate the biomarkers, the SERPIN1 and the gene methylation at preoperative, at 6-month follow-up, and then compared it to the control group. And both baseline SERPIN1 protein and baseline SERPIN1 gene methylation were significantly higher in patients than in controls. As you can see here, when you compare the purple to the orange, it is significantly higher. Interestingly, at 6 months, the SERPIN1 protein dropped significantly, that it almost reached the level of the controls that, you can see this difference was not even significant. So surgery managed to drop the SERPIN level up to the level of normalization. Conversely, when we looked at the gene methylation, the drop was not significant. Obesity generally involves an inflammatory state with increased insulin resistance, as seen here with the HOMA-IR and CRP levels high in the patient group as compared to the control group. However, at 6 months in green, there was a significant drop in both HOMA-IR and CRP levels. However, it still didn't normalize because, as you can see, it was significantly still higher. But you can argue that this is still 6 months. Maybe at 1 and 2 years, those patients' levels would drop, but we didn't measure that yet. We also found a significant correlation between baseline SERPIN1 gene methylation and anthropometric measurements along the follow-up periods up to 2 years. However, correlation between post-operative SERPIN1 protein and anthropometric measurement were found insignificant at 6 months and 1 year. However, they were only significant at 2-year follow-up. We then further went a step ahead and did a subgroup analysis where we divided our patients into 2 subgroups according to their percentage weight loss, into responders and non-responders, where we found that responders had a significantly lower gene methylation both at baseline and at post-operatively when compared to non-responders. So responders had lower levels, so this can predict whether they lose weight or not. When we looked, however, when we looked at percentage excess weight loss, and when we divided them into responders and non-responders, this was only significant at baseline gene methylation. We then did a ROC curve analysis of methylation to predict the response to weight loss at 6 months after surgery. And this displays a 76% sensitivity with a 84% specificity. Again, at 1 year, this raised to 100% sensitivity and 93% specificity. And then at 2 years, again, 100% sensitivity with a specificity of 54.6%. So in conclusion, we can conclude that baseline SERPIN1 gene methylation could serve as a predictor of successful weight loss after sleeve gastrectomy long-term up to 2 years. And post-operative SERPIN1 protein could be a potential predictor for a maintained weight loss after sleeve gastrectomy. And accordingly, the use of those biomarkers could be a good predictor to the outcome of bariatric surgery and could pave the way for a new era of personalized nutritional and bariatric therapy. Thank you for your time.
Now, I would like to thank the organizing committee for allowing me to present this paper in the following virtual conference. The paper about the conventional versus distal laparoscopic 1 anastomosis gastric bypass, a randomized controlled trial with 1 year follow-up, is presented by Dr. Tamer Mohammed Nabil, Professor of Surgery, Bani Suef University in Egypt. The author volume of work in 2019 is 291 cases, and thanks to God, there is no serious complication in the cases. The volume is about 86% sleeve cases, 10% bypass, and 4% redo cases. This is a randomized controlled trial involving 60 patients suffering from morbid obesity in 2 university hospitals. We compare 2 techniques of laparoscopic 1 anastomosis gastric bypass regarding weight loss, nutritional deficiencies, the resolution of obesity-related comorbidities, and the quality of life. The first technique is a conventional technique involving gastroenteric anastomosis, 200 centimeter from the ligament of Treves, and the distal technique involving the gastroenteric anastomosis, 400 centimeter, but from the ileocecal valve. Total small bowel length should be measured in all cases, and cases with total small bowel length less than 600 centimeter or the total small bowel length couldn't be measured are excluded from the study. This is the way the measurement of the total small bowel length using a 10 centimeter nylon tape along the anti-mesenteric border of non-stretched small bowel. In the present study, the total small bowel length ranged from 440 to 1,000 centimeter, but cases with total small bowel length less than 600 centimeter are excluded as mentioned before. There were no complications related to bowel handling during the process of bowel measurement. In the whole studied group, the total small bowel length was not correlated with age and BMI, but it was positively correlated with the baseline weight and height. And this is a concept diagram about the study. We enrolled 70 patients randomized in 2 groups. 2 cases, the total small bowel length couldn't be measured, and 8 cases, the total small bowel length was less than 600 centimeters. So the 10 cases are excluded from the study. And final, we analyzed 60 cases, 30 in each group. The actual weight, BMI, and the percentage of excess body weight loss at 3, 6, and 12 months were evaluated, and the resolution of obesity-related comorbidities and some nutritional deficiencies at 12 months using the following laboratory tests. Quality of life assessed using a translated version of gastrointestinal quality of life index at 3, 6, and 12 months after surgery. Table 1 shows that the 2 groups were comparable regarding age, sex, baseline weight, height, and BMI. Most patients were super obese with no significant statistical difference between the 2 groups. Table 2 shows that there was no significant statistical difference between the 2 groups in the baseline laboratory characteristics prior to surgery. Table 3 shows that there was no significant statistical difference between the 2 groups in the baseline frequency of obesity-related comorbidities. And also in Table 4, there was no significant statistical difference between the 2 studied groups regarding total small bowel length, with mean total small bowel length 715 centimeter in the conventional group compared to 728 centimeter in the distal group. But the afferent limb to total small bowel length was significantly higher in the distal group, with mean afferent limb length 300 centimeter compared to fixed 200 centimeter in the conventional group. Table 5 shows no significant statistical difference between the 2 groups in the actual weight and BMI during the follow-up visits at 3, 6, and 12 months, and the percentage of excess body weight loss were comparable up to 12 months after surgery, with excess body weight loss percentage 63% in the conventional group compared to 69% in the distal group after 1 year. Table 6, after surgery, the hemoglobin deficiency increased significantly in the distal group. Similar changes occurred in iron deficiency. It became significantly more frequent in the distal groups. 11 patients of the distal group developed hypoalbuminemia compared with only 2 of the conventional group. Also, the level of the Barras hormone was significantly higher in the distal group 12 months after surgery. Table 7 showed that preoperative obesity-related comorbidities significantly improved in all patients without significant difference between the 2 groups. And Table 8, the gastrointestinal quality of life index score at follow-up visits after surgery was significantly higher in the conventional group. Many variations to the length of the bypass limb of one anastomosis gastric bypass have been suggested to improve the weight loss and reduce protein malnutrition. However, there is currently no consensus on the ideal limb lengths. The length of the small intestine varies greatly between 300 to 1,000 centimeter among patients. Therefore, routinely bypassing 200 centimeter of the small bowel without any consideration of the total small bowel length may hence put some patients at risk of malnutrition or insufficient weight loss. Most surgeons don't routinely measure the total small bowel length while performing bariatric surgery. So there is risk of short bowel syndrome and malnutrition on one hand, versus the weight regain and the continuation of comorbidities on the other hand. This study demonstrated that in one anastomosis gastric bypass, bypassing the proximal 200 centimeter of small bowel or leaving the distal 400 centimeter active was similarly effective regarding weight reduction and resolution of obesity-related comorbidities up to 12 months. The percentage of excess body weight loss was not correlated with the percentage of afferent loop length relative to the total small bowel length. And the distal group showed significantly lower hemoglobin, iron, and albumin with significantly higher paras hormone levels 1 year after surgery compared with the conventional group. The gastrointestinal quality of life index score at follow-up visits was significantly higher in the conventional group, and it was negatively correlated with the percentage of afferent loop length to total small bowel length. In the current study, the two surgical techniques, whether the conventional or the distal, were safe with no significant early or late post-operative complications. One anastomosis gastric bypass can achieve satisfactory results when the afferent loop length is 200 centimeter, and bypassing more than 200 centimeter of the small bowel doesn't improve the weight loss or resolve comorbidities significantly, and it's associated with more frequent nutritional deficiencies and lower gastrointestinal quality of life index score. To guard against excessive shortening of the small bowel that might increase the risk of nutritional consequences, measuring the total small bowel length is recommended. And final key point, surgeons in bariatric surgery concentrate on anatomical factors. There is misconception that if we create same gastric pouch bypass the same length of the small bowel, while the total small bowel lengths are equal, patients will lose same weight if they eat the same food. While this works in most cases, it doesn't work for some. We underestimate the physiological factors. What about the power of digestion, the power of absorption of functioning GIT after bypass? Are they similar in different patients? We need to find ways to measure this power in order to find the ideal bypass length to get best weight loss results without devastating nutritional consequences. Thank you.
Thank you, Dr. Tamer Abdelbaki and Dr. Tamer Nabil for these excellent presentations. Now we're going to give our two discussants the chance to critique your well-done published studies. So the discussant for the first case, which is the SERPINE1 gene methylation and protein as a predictor for weight loss, is Dr. Khalid Hamdan. Dr. Khalid?
Yes, can you hear me?
Yes.
Yeah, okay. At the beginning, I would like to say that I'm privileged to critique and comment on this fantastic paper that I thoroughly enjoyed reading. It's very rarely that we see in our region some basic science research papers, which hopefully will bring us a little bit closer to answering some of the difficult questions that we're facing in bariatric surgery. And the paper focuses on a very critical issue. There is very little work has been done to try and bring our understanding a little bit closer to what the real answer is. And the question the paper really focuses on is can we really predict responders from non-responders after bariatric surgery, and in this particular paper, laparoscopic sleeve gastrectomy. They used cutting-edge science advances, for example, measuring the SERPINE protein levels and gene methylation And this has recently become accessible to all of us because of advances in medical techniques. Now, the authors, as I said at the beginning, it was easy to read the paper. The introduction was very clear. The focus, again, was very clear on the main issue the paper is trying to tackle. The methodology, I thought, was solid, despite its complexity, because there were many variables the authors were working with. And their statistical methods were also sound. Now, the discussion, the results, there were different variables, as I said, and the authors were trying to correlate those variables with weight loss at 6 months, 1 year, and 2 years. And the two main variables were the SERPINE1 protein levels and gene methylation. And there were some positive correlations between the SERPINE level and gene methylation with changes after surgery. And I will not go into the details of their findings because they've done really well to present them in the presentation. Now, what I would like to focus on is some features of the study that might improve the results if the authors wish to take this a little bit further in the future. The first thing to say is that the sample of the study, they used 50 controls and 50 in the study group. And they did mention that they did some work on calculating the sample size, but I felt that 50 is a little bit of an underestimate. Their control group were patients of normal weight, and I think it would have been useful to have another control group who have weight and characteristics, particularly weight and BMI, that are matched to the study group and follow the SERPINE level and gene methylation during the same study period to see if there are other factors that affect their results. They also correlated the two main variables, SERPINE level and gene methylation, with weight changes at 6 months, 12 months, and 24 months. But they did this only for gene methylation, and it would have been nice, they might have done it, but it wasn't very clear from the paper whether they've done it for SERPINE protein levels. So overall, there were some positive findings there, interesting, because we are very much in need for predictors of who's going to respond to our intervention, laparoscopic sleeve gastrectomy in this case, and who isn't before surgery. A lot of the studies that are currently being done focus on patients' characteristics such as compliance, patients' visits, BMI, age, sex, to tell us as surgeons who's likely to get a good result after surgery and who is unlikely to get good results. This study is different, and I think it looks at the issue at a cellular and molecular level. And as I said at the beginning, this is one step further. This is an asset to the literature that has been published on this topic. So I commend the authors. I think to summarize, I don't want to take too much time here. The study was well constructed, clearly written. The results were very easy to understand with the way the authors presented them. So I have nothing but positive remarks to say about this paper, with just a few critical questions about the control groups. I think I would have liked to see a control group with similar weights and BMIs to the study group.
Thank you.
Thank you, Dr.
Excellent, excellent points. Tamer, before we give you a chance to answer or to reply to all of these, I just want to ask if Dr. Kasama has anything to add as well before we move to the next case.
Thank you, Dr. Khalid. Actually, I have to apologize all of you that I skipped the introduction to Dr. Nimeri before his lecture. Because yeah, that was really my bad. So I would like to say that before the discussion, Dr. Nimeri is still here. If you have a question for him, please write some question for him and some speakers here on the chat box. Thank you.
Thank you, Dr. Kasama. Tamer, precision medicine is the future, and it would be ideal if we could choose our patients preoperatively. After you address Dr. Khalid's points, one quick question. How far do you think we are from offering such a service, the thing that you described in your paper, to our patients in daily life? Tamer, you're muted. Tamer, we can't hear you.
Yeah, now I'm working. It's working. All right. First of all, thank you, Dr. Ashraf, Dr. Kasama, and Dr. Hamdan, and Dr. Trila, and my colleague, Dr. Tamer Nabil. I appreciate Dr. Hamdan's critique. And yeah, to answer directly Dr. Ashraf's question, yes, we're pretty close because, you know, the number one question, is it feasible? Is it cost effective? We found out that it should, you know, relatively the cost of doing those tests per patient should be around $100 or a bit less. So we're not far out from doing. We could have did the test on the gene level on fat samples, visceral samples, or even more invasive biopsies, but we specifically chose blood samples again to focus on the reproducibility of such a test. To answer the most common question that we all get at our office is, doctor, how much am I gonna lose weight or not, and what's the outcome? What's the maintenance gonna look like? So I think it's a credible question. If we can answer our patients, definitely this would be groundbreaking. Not only that, there has been studies coming out of Spain that looked at probably some patients, as you've seen in our study, baseline methylation was high. So they went ahead with some patients and did a nutritional plan that managed to reduce the methylation. By the way, in our study, bariatric surgery didn't achieve this methylation level. So they sort of helped drop the methylation levels on the DNA level. Maybe our patients can benefit from like a short-term diet plan, maybe medications, liraglutide, or any measures that can, again, ultimately improve the outcome. And to answer Dr. Hamdan's critiques, which is, I really appreciate your kind words on our research. We are actually, this project is an ongoing project. It's we're currently looking at 5 years now results. We are recruiting new patients for another second arm study to compare same matched controls to sort of look at. But at the beginning of our first project, we wanted to take the patients themselves as controls. So at baseline and then at 6 months, we can look at their methylation. Obviously, methylation didn't change at 6 months. We're also looking forward on exploring bypass, whether bypass would have a different effect than the sleeve gastrectomy. But we sort of, you know, started with the sleeve with those first 50 patients, and hopefully with a longer follow-up and competitive study between the two procedures.
Thank you, Tamer. Excellent work. In the interest of time, we're going to be moving to the second case. We have our dear colleague from Lebanon, Dr. Eli Chilala. He's going to discuss the very debatable topic of limb length with the one anastomosis gastric bypass. So Dr. Chilala, we're looking forward to hearing your critique of such an interesting paper by Dr. Tamer Nabil.
Yeah, absolutely. Thank you, Ashraf. Thank you, everyone, for being here, and thank you for the IFSO MENAC to give me this opportunity to be panelist with you and review this paper with this, I would say, an excellent, courageous presentation and study with the results analysis. I will go very quickly on the paper because I have some questions, more questions on the methodology. So the cohort, the small size of the cohort is, as you mentioned in your paper, is there is a limitation. It's a small numbers of study, 60 cases. The short follow-up of 1 year in this particular hypoabsorptive procedures is very low. It's 1 year only, and we know that the multi-deficiencies and problems of weight loss will come over 2 years or 3 years or 4 years. So we are looking forward to get the results on 2 or 3 years afterwards. So by the introduction of the paper, it's very well introduced and it's well explained. It's very clear. It's well written. The criticism on the analysis are perfectly well done, statistically well done. But I have an issue or concern on the methodology. I didn't find the rationality for choosing 400 centimeter for the common limb for the distal technique, and why did you choose this 400 centimeters electively, and what is the rationality behind it for everyone, and why 200 centimeter for everyone, as it might, and we know it might affect the malabsorption and malnutrition in all cases. Why did you determine it for those patients independently of the BMI of these patients? So this is my concern for the methodology, and the explanation for the measurement of the limb. Would you consider that the excluded, you didn't determine in the exclusion patients, which represent 16% in the distal group, 6/36, what did you do with those patients? And with the conventional also, there is 11 or 12% of cases were excluded. What did you do? And we are having a concern of these limitation patient of having less than 600 centimeters, that you are giving them, we are giving them a malabsorptive procedure by a BP limb of 200, more than 200 centimeters. So it's likely you excluded, but you didn't explain why did you exclude those patients. What did you do with this with these patients? So it's obviously one missing in this study. Regarding the message for the readers, it's clearly well presented, and the message of there is no effect of the alimentary limb towards the total small bowel length, and it's very important to measure every time, everywhere, the small bowel lengths, and determine what would be the proportion of the malabsorption by the excluded limb. It's clearly explained, but you didn't respond on the expectation that you mentioned in your discussion. Therefore, in the current study, we speculated whether there is an ideal percentage of bypass limb length in relation to TSBL, and you didn't answer this expectation. Would you have an expectation for this? Would you go like Professor Nimeri presented as 1/3 of biliopancreatic limb bypass for 2/3 for the TSBL? So the proportion, as you get it in your article, you mentioned in the distal group that you had 40, the alimentary limb to the total small bowel limb was 47.3%, where in the conventional it was 35.3%, which means that you are more in the conventional way good for malabsorption. Less than 30% would be better to not to have malnutrition deficiencies whatsoever. So I would say the answer of your expectation would be valuable to the readers, that probably less than 1/3 of the biliopancreatic limb or the alimentary afferent limb would be good for the OAGB as a general. I probably would you agree with this? And this will support in your study that you have this difference of percentage that is significantly, statistically significant. So these are the most important and it's the paper highlighted the most important deficiencies that you have in the distal group that we have to be aware of: anemia, iron deficiency, hypoalbuminemia, etc. And this is very important to mention and to control it, but I would have preferred it to get it on long term more than on short term. So definitely the paper is very good, very interesting, and I just have these two weak points in the paper to highlight rather than overall a very nice paper. Thank you.
Thank you, Eli. Tamer, your responses, and congratulations on your presentation. Just unmute yourself, Tamer. We still can't hear you.
Yes, I am in now. Thank you to be with you in this virtual conference, and I'm totally appreciated to Dr. Shilala for his critique. I think he has all the rights of what he said. Regarding the questions he asked about why we choose 400 centimeter from the ileocecal valve, that is the issue. We have a long history about 50 centimeter from the Scopinaro technique till the SADI 250 or 300. So we prefer to be away from the hassle by doing a larger absorbing common channel, which is 400 centimeter. We also we have the hypothesis that the average length of the small intestine is about 600 centimeters. So if we are usually bypassing 200 centimeters from the starting point, so and the average length will be 600 meters, so we speculated that 400 centimeters from the ileocecal valve will be safe for the patient regarding the nutritional problems that can be happened that prevent us from reversal of or lengthening of the common channel. This regarding the 400 centimeter from the ileocecal valve. Regarding what we did with the cases that are shorter than 600 centimeter, actually we did the same procedure like Dr. Abdurrahman Numeri. We bypassed 1/3 only of the total small bowel length. So if the total small bowel length was 390, so we bypass only 130 centimeter from the ligament of Treats. But we didn't mention that in the study because the study is only limited to, and these cases are excluded from the study, so we didn't mention what we did with these cases. So regarding these 2 points, I don't know whether another point want to be clarified else from Dr. Hilala.
Now, I just mentioned the expectation. What would be as a resulting of your study? What would be your current proposal for the readers? What would you expect?
My current proposal of the readers, if you should measure the total small bowel length. So if the total small bowel length is 6 meters and more, no more than 200 centimeters will give a good results. But if the total small bowel length is less than 600 centimeters, it's better to go for 1/3 only for the afferent limb.
Yeah, but the bias is that in your study, the most of your small bowel length of the afferent limb is more than 300 centimeters at that, and this would be more responsible of the multiple deficiency and malnutrition rather than the 400 centimeters of the total small bowel. You understand the bias in your calculation, in your methodology? So I think that in those distal technique, you have patients over 40% having more than 300 centimeters of the afferent limb.
Yes.
So the malnutrition and deficiencies will get from this issue, from this problem.
So
actually, this study is still going for the, but we published it at 1 year. Actually, we reversed till now 3 cases from the study because the hypoalbuminemia not corrected by any means. So we did the reversal of the procedure. The patient even refused to do shortening for the length of the bypass length. They insist for the reversal from the malnutrition, but this is not published yet, but actually this happened.
Thank you.
So it's very important what you mentioned to avoid this issue and this problem, not to to measure all the small bowel length and to consider maximum of 1/3 for the afferent limb. Maximum 1/3 of the afferent limb, not to avoid this malnutrition, deficiency, etc.
Totally agree.
Thank you for your honesty and your courage for doing this.
But also, as I mentioned, we have a shortage in the problem that we concentrate on the anatomy. We have a problem in the physiology. We don't know what about the power of the absorption and the power of the digestion of the functioning intestine after bypass. We need a study for this. We need studies to do the power of absorption, so we can reach to the ideal length without compromise on the nutritional issues.
Tamer, quick questions from the audience because we're almost out of time. So Dr. Suarez from Latin America is saying, in Latin America, most patients has an average height of 1.65 meters and the bowel length of 700 centimeters. What was the average height in your study population?
The average height is mentioned in the tables is 728 centimeters.
Okay, and we have a question from Ahmed Al-Wasabi. He's asking, why would I measure the total length if both groups have similar outcomes if the average length is 6? So
the problem that you don't know the length. If it's shorter than 600 meters, you will put yourself in a very problematic situation. If the length was 400 centimeters and you bypassed a routine 200 centimeters, so the rest of the common channel will be 200 centimeters only.
That's why they excluded.
Yes,
that's why they excluded from the study. And 200 is very, very high for all the population, all the BMI.
He excluded the people who are at highest risk of becoming malnourished if done in that way, as Dr. Shalala said. We have 3 minutes left, and I'm gonna leave them open for comments from Dr. Kasama. Dr. Kasama, any questions to the authors? Anything you want to add?
Yeah, I really enjoyed both of 2 papers, and a very scientific one. And I agree with Dr. Nabil that it's very important to count all the small bowel lengths, because I think it's different among ethnics. For the Japanese and the American, the Brazilian, and probably Arabic people are different. So that it's very important to measure the length and important to check the BP limb. I think the BP limb is very important, as Dr. Kelala said. So to avoid any complication of malnutrition, so it's very important to do that. Thank you.
Thank you. Yes, Eli, final comment from you.
Yeah, just a short question, which would be very interesting. What would you do if you have reversed a Roux-en-Y gastric bypass? How would you distalize your gastric bypass on the biliopancreatic limb? And what would you do in your current practice, Dr. Nabil?
Me? Yes. Yeah. Actually, I will lengthen the biliopancreatic limb.
How far? Which proportion? What would you do?
I will measure the whole common channel, and then after that I will lengthen the biliopancreatic limb by 1/3 of the common channel.
Thank you.
Thank you.
That's good.
That discussion could go on for
Yeah.
hours, but we're gonna have to end this beautiful discussion here. And please stay with us for the second part of the top paper session.
Thank you.
Thank you.
COVID-19 has changed a lot of things. The way we live, the way we work, the way we care for patients. One thing that hasn't changed is Ethicon's unwavering commitment to support nurses, doctors, and everyone who works for and with hospitals. We're looking towards the future and expanding virtual surgical training to educate doctors and clinical staff all over the world. We're focusing our portfolio on the tools that help surgeons and patients. Things like Plus antibacterial sutures, Dermabond Prineo, and Stratafix that help to reduce hospital stays, increase efficiency in the OR, and allow patients to recover at home. And we're accelerating new innovations, including remote wound monitoring. Every day brings challenges and opportunities. We're here, we're ready, and we're in this together.
Novo Nordisk has proven its compassion and commitment to the health of millions. Now, Novo Nordisk is expanding that compassion and commitment to another serious disease, obesity. For many people with obesity, managing the multitude of challenges associated with their weight is a lifelong journey of ups and downs, and a substantial burden on their health. It's time for a new solution. A solution that addresses the problem the Novo Nordisk way, by combining science with compassion and a deep understanding of patient needs. A solution that recognizes obesity as a disease and embraces the possibility of dealing with it and its potential health risks in a significant new way, so patients can embark on a new weight loss journey. And this is where it begins. Welcome to Saxenda. Novo Nordisk proudly introduces the first GLP-1 receptor agonist approved for chronic weight management, creating a journey patients can look forward to, helping them lose weight and keep it off. Saxenda. It's about change. It's about hope. It's about a healthier future.
Ladies and gentlemen, please take your seat. Next session is going to start in a few minutes. The chairperson of this session, Dr. Shikora and Dr. Herrera, are kindly requested to turn their camera on and start the session, please. Thank you.
Good evening, everybody. Welcome to the top papers, IFSO MENAC Part 2 session. We've got two very, very interesting papers to hear about today, and we'll have discussions by Professor Khurshid and Professor Al-Nami at the end of the presentations. I want to thank my co-chairman, Professor Miguel Herrera from Mexico, for joining me for this. Miguel, any comments?
No, thank you very much. Good evening, everyone. We are looking forward to hear the presentations.
So without any further ado, I'd like to invite the first speaker, Dr. Ayed Al-Khatani, professor and consultant of minimally invasive and obesity surgery at the College of Medicine, King Saud University and King Khalid University Hospitals in Riyadh. Professor, please present your paper.
Thank you, the team, and thanks for this. Thank you for the opportunity to present our presentation. We'll be talking about outcome of endoscopic sleeve gastroplasty in 1,000 consecutive patients. We know bariatric and metabolic therapies have sparked significant interest as minimally invasive therapies for weight loss. It is usually divided into gastric and small bowel intervention, and many of them brought their concept from surgical concept, whether in the stomach or the small bowel. If you look, there are a list of procedures done currently through bariatric in the stomach, as you can see, from balloons, endosleeve, pose, endozib, chattels, and so on, to those in the small bowel, as you can see on the right side. One of the most frequently studied procedure nowadays is overstitch endoscopic sleeve gastroplasty, in which we do full thickness suturing of the stomach from inside, resulting in almost sleeve-like structure and minimizing the size of the stomach up to 60%. Still, there are some questions about safety and efficacy of this procedure, and many questions are not yet answered with this in this regard. We conducted this study to evaluate the safety, efficacy, and short-term outcome in terms of weight loss and in terms of also comorbidity resolution. We are collecting our patients' data in a database from 2016 to 2018 with a CRF form for each patient. And in this, we are collecting weight loss, comorbidity resolution, postoperative complication, mortality, morbidity, and other outcomes related to this procedure. Now, this is the technique where you go inside the stomach through the scope with the overstitch on it, and you grasp the stomach using helix, and you pass the needle starting at the anterior wall of the stomach, greater curvature to the posterior wall, and going backward. This is the first year, and we can hear that it will result, continuing the procedure, you will have almost, when you look at the procedure at the end, is the pylorus, pre-pyloric area, and you'll see it almost tight, as you can see. If you look to the procedure, and this is very interesting view in a patient.
This conference will now be recorded.
I would like to thank you for giving this opportunity to present our study on 1,000 consecutive patients undergoing endoscopic gastroplasty. Endoscopic bariatric and metabolic therapies have sparked significant interest as minimally invasive therapeutic option for weight loss. We think this procedure is forming a bridge between lifestyle and bariatric surgery, and it is divided into two components, one in the stomach and one in the small bowel. And many of these concepts in a small bowel or the stomach are derived from initial surgical concept in the past. You can see a list of procedure in the stomach to initiate weight loss, from gastric balloon into sleeve pose into zip and so on. And then you have other procedures in the small bowel, which are very frequently nowadays under evaluation and under study, and some of them result in significant weight loss and even resolution of comorbidities. One of the most important procedures nowadays in endobariatric is overstitch endoscopic sleeve gastroplasty, in which we tighten the stomach through full thickness suturing, and we reduce the size of the stomach up to 60% from inside. And still some questions about the safety and efficacy of this procedure, i.e. endoscopic sleeve gastroplasty or ESG. And we conducted this study to evaluate the safety, efficacy, and short-term outcome of this procedure. We have collected the data from our database from 2016 to 2018. Each patient has his own or her own CRF form, collecting weight loss, comorbidity resolution, postoperative complication, mortality, morbidity, and other outcomes. This is the procedure as a technique where we go inside the stomach and we grasp the stomach through helix. We pass the sutures in, starting from the anterior wall to the greater curvature to the posterior wall, and then we go back in a U-form like or U-shape like pattern. Some of it, or nowadays we call it square shape or other shape, but in any way, we tighten the stomach from inside, as you can see on this picture. End of the day, you will see the stomach very well tightened, as you can see here. This starting from the pre-pyloric, going all the way to the hiatus, and you'll see very small size stomach using plication from inside. If you look from the outside, as you can see in this video, which is very interesting, this is a patient where we had endoscopic gastroplasty, but at the same time lab chole. So we recorded from outside, and you can see the helix is going through the wall, the suturing is full thickness, and the size of the stomach is reduced and forming a sleeve-like structure or configuration, as you can see. If you look on the X-ray, you'll see very reduced stomach size. Currently, up-to-date result is 2,700 patients, and the study which we are talking about is about the first 1,000 patients of these patients. The average BMI is 33. The recommended BMI from 27.5 to almost 35. So it is in those categories that are not yet candidate for bariatric surgery. Weight loss on almost 2 years nowadays, but the first year and a half, 67% excess weight loss, which correspond to 15% total weight loss. If you look to the comorbidity resolution, this is on the left side, you can see the weight loss in a year and a half in this study, the 1,000 patient, 64 excess weight loss, which is almost close to 15% total weight loss. Comorbidity resolution, hypertension resolved in all patients, which is very interesting. I think if we capture it early and we intervene early, we will result in resolution. Diabetes, up to 60% resolution, and other are improvement. Some patients required reversal to sleeve gastrectomy. Some patients required, as you can see here, redo of the procedure, i.e. another ESG, to retighten it or redo or suture some other area that resulted in opening of the sutures. And most of the patients, as you can see, were really doing well. There is no problem. Some of them will require revisit, as you can see here, to the ambulatory care for rehydration and analgesia. And we will go over some of the complications. If you look to subdivision of those patients who are diabetic who improve with the techniques, most of those patients or all patients who were on oral hypoglycemic agent had resolution or improvement, almost 100% resolve if they are newly diagnosed, and if they are still in oral hypoglycemic, almost 100% resolve or improvement. And if they are in insulin or in oral and insulin, then that result will decrease. And this is the same as it is in bariatric surgery. The adverse event, fever without related collection, and most of them, they will resolve in 24, 48 hours. So we cover them with antibiotic. Perigastric collection, some of them will require intervention, some of them just observation and antibiotic. And transfusion for those who had some bleeding. We had 7 patients who had blood loss, but only 2 required transfusion. And some patient, 3 patients, in fact, 0.3%, required or asked to remove the switchers because of pain. They cannot tolerate the pain. Most of them, they will tolerate the pain and in 2 to 3 days, and that will resolve with time. Very rarely you require to undo the switchers for pain control. If you look to the durabilities, this is 1.5 years patient. And if you look, you can cut the switcher, as you can see. So it's reversible. If they might form bridge-like, as you can see here, we can reverse them, we can cut here. It's not really something difficult if you see the switcher. If you don't see the switcher also, you can also go in the fold, as you can see, and you will cut it and it will open. So this is as it's really open up. So there is it will stay and it will improve. This is a very interesting film to show you the reversal. If you compare the result to banding, it's almost the same. So in the graphs here, you can see it is almost better than band, but less than sleeve in terms of weight loss. We can reverse it to laparoscopic sleeve gastrectomy. You can see on the right side in the video, there are some adhesions, there are some anchors or some needle penetrating the wall of the stomach. They should not cause a problem, but they might cause pain. When you reverse, you be careful about this. So we remove the switcher from inside the stomach. Then we do routine sleeve as you can see in this video. So sleeve is a routine. We go inside, we look from inside, we see what is, these are the switcher as I showed you before. You remove them, you remove all needles and anchors there. And after that, you go for, after you clean the stomach from inside, you go and do sleeve. So we start with sleeve, mobilization, then inside, then outside. Can be done in different age group. As you can see here in pediatric, we have done 148 patients in pediatric with the result in the same weight loss, total weight loss. Many studies have shown that it is significantly reducing weight loss, up to 60% excess weight loss in multiple regions and multiple surgeon and multiple experience. So it's reproducible in terms of weight loss. Again, this is the same, showing 60% excess weight loss in 1 year, 2 years. Also, that will correspond to almost between 14 to 19 total weight loss, which is also shown in multiple studies. If you look to the Brazilian consensus, which is very interesting, recently published in 18,000 patients, in 1,800 patients, there was hematemesis, as we have seen in our cases, prolonged pain, which is expected, persistent vomiting, respiratory insufficiency, which is very unusual, laparoscopic intervention in gallbladder puncture and 2 abscesses, death due to pulmonary embolism. Now, it is very safe procedure as a long term, and still there are some comorbidities that could happen, or morbidity that could happen, but it is very rare. And if you look to the procedure profile, in our experience and in other people's experience, it's very safe procedure. Is it going to maintain this weight loss and this result for 5 years? That's the study just recently published. 90% maintain 5% total weight loss and 10% total weight loss, 60%, sorry, 10% total weight loss. So 60% of those who underwent the procedure will maintain 10% total weight loss after 5 years. In conclusion, ESG appears to be well tolerated, safe, and effective. Significant weight loss occurred during the first 18 months, and most of them will maintain it up to 5 years and more. Some patients require revision or reversal, and that's easily done and safely done. ESG serve as middle ground solution between lifestyle and behavioral modification and bariatric surgery. It is not a replacement for bariatric surgery. It's a solution that's provided for patients who are not candidate for bariatric surgery or patients who are completely rejecting bariatric surgery, and result in these weight loss and also resolution of comorbidity up to 100% in hypertension and more than 60% in diabetes. Thank you.
Good evening. My name is Dr. Adar Samir. I'm an assistant professor of general surgery in Cairo University. I would like to thank the IFSO for inviting me to speak in this Congress, and thank the moderators and all of you for your kind attention. I'm going to be speaking today about greater curvature as a gastric pouch for sleeve gastrectomy, and a bariatric procedure, feasibility study, and a canine model. I have nothing to disclose. Sleeve gastrectomy became the most popular bariatric procedure for key points, key advantages, like being simple in technique, no segmenting exclusion, preserving the pylorus, and other things among very well weight loss and metabolic control, so comparable to a far more complex bariatric procedure. But the question is, does it need a modification? Of course, sleeve is not completely perfect, as two main concerns after leakage from the proximal staple line and GERD are direct consequences of its taking. Leakage previously reported between 3 to around 6% of cases. More recently, in large, serious, and experienced centers, this number dropped to 1 to 2%, which is great to experience and different staple line reinforcement techniques. But what's really worrisome is that more than 90% still happen at the proximal staple line. There is something wrong in this area. Given the fact that the left and right gastric vessels, which are the only remaining vessels supplying the sleeve, are considered by anatomists to be an end arches, which do not share in submucosal plexus, as they pierce the submucosal plexus and directly supply the mucosa of the lesser curve. Proximal staple line is not part of the lesser curve, which leads, which causes loss of blood supply of this area due to severed submucosal plexus by stapling, and the interrupted left inferior phrenic vessel and posterior gastric arteries, which usually used to directly supply this area. This leaves the only blood supply for this area from the cardioesophageal branch, supplying this area in only 78% of specimens. As a result, a considerable sector of sleeve gastrectomy patients have relatively ischemic proximal staple line, which make them liable to leakage. As for GERD, sleeve cause GERD due to many reasons, like resected string fibers, lowering the alias, resting pressure, blunting the angle of Hess, interthoracic sleeve migration as a result of the previous twist due to loss of gastric attachment, and resected the gastric pacemaker area on the greater curve can also contribute to that. Our technique can offer a possible solution for the aforementioned sleeve gastrectomy technical shortcomings while maintaining its basic advantages. The rationale of our technique is demonstrated in this hand-drawn sketch, as our technique is simply an obverse sleeve gastrectomy, as the gastric tube will be constructed on the greater curve instead of the lesser curve. The technique starts by dissecting the lesser curve, jerks the gastric, avoiding injuring the lateral G nerve, starting at the insula angularis and upwards to reaching distal to the first branch of the left gastric vessel. After that, we dissect any retrogastric adhesion and free the extraperitoneal part of the pelvis. Then we insert the 36 French bougie along the greater curve and start stapling, starting at the incisura in a C-shaped manner, as shown in this picture, to reaching the distal part of the dissection. And then, with the resected part in blue color removed from the picture, we see the layout of the pouch with the blood supply. We only transect some branches of the left gastric artery and the posterior gastric artery, which leaves the gastric pouch well supplied by the proximal branches of the left gastric artery, the right gastric artery, the right gastrocolic artery, and the left gastrocolic arteries, short gastric arteries, and left inferior phrenic artery. providing a robust blood supply for the whole length of the staple line. As for the anti-reflux features, our technique leaves a completely intact lower esophageal sphincter with all of its components and the angle of vessel kept in acute fashion, and also preserve all the attachment around this area and other areas, especially to the diaphragm, to the gastropharyngeal ligament and the phrenosophageal membrane, and to the left loop of the liver, to the pars condensa, and to the spleen and to the transverse colon, providing a C-shaped, gentle C-shaped pouch, which maintain proper luminal patency and avoid twists, and also keep the sleeve intra-abdominal. Above that, it provides also a form of superselective vagotomy, which can minimize the acidity and the need for PPIs post-operatively. Most importantly, preserve the gastric pacemaker area, where gastric contractions are initiated and propagated intrinsically in all directions. As studies done by dynamic MRI on sleeve patients found that the vertical length of the sleeve is almost immotile due to resection of this area. In our study, we included 13 stray mongrel male dogs divided in 3 open surgery groups: greater curved sleeve gastrectomy group, where they had our technique, 5 dogs, and standard sleeve gastrectomy, they had standard sleeve gastrectomy, 3 dogs, and sham group, where they had a laparotomy without any gastric manipulation, followed by closure. Picture on the right demonstrates with the white arrow pointing at the proximal part of the staple line of our technique, and the black arrow pointing at the distal part of the staple line. Picture on the left shows the gastrocolic ligament fully intact and inserted at the outer border of the sleeve. Dogs' weights were measured on day of surgery and at the end of week 2, 4, 6, and 8, and then compared with other groups. Greater group lost 24.7% of their initial weight. Standard sleeve gastrectomy group lost 25% of their initial weight. Sham group gained 8%. Both gastrectomy group had no significant difference in weight between them, while greater curve showed significant difference from the sham. Dogs in both groups of greater curve and standard sleeve gastrectomy vomited some of their meal immediately after finishing the meal in the first 3 to 5 days, probably due to rapid overfeeding, as vomiting stopped spontaneously as the dog adapted to the meal capacity, which is reflected by the overall reduction in food intake, which was 55% in greater curve group and 58.3% in standard sleeve gastrectomy group, with no significant difference between both. We had no post-operative complication on all groups. But weight loss in both gastrectomy group cannot be only attributed to the restricted nature, as accelerated gastric emptying and reduced serum ghrelin, another known mechanism for loss weight after sleeve gastrectomy, that which we need further studies of these mechanisms in our technique. During autopsy, which is done at the end of the study period, the 8th week, the gastric sleeves of greater curve group showed excellent healing with no stenotic lesions or kinks or necrotic ulcerations. Our results regarding weight loss were comparable with other restrictive similar procedures published in obese and non-obese canine models. Our study had some limitations, and sample size was small, short for a period, and they're completely focusing on the feasibility of our technique on dogs. In conclusion, greater curve sleeve gastrectomy is technically feasible in a canine model. Larger studies with longer follow-up period will be needed to assess weight progression and resolution of metabolic comorbidities. Back in 2017, we believed that our technique can be performed laparoscopically in morbidly obese patients, following similar steps to laparoscopic sleeve gastrectomy. Now we know that for certain. Thank you.
Thank you very much for those great presentations. I think now we're going to have the discussants review the papers, and the first discussant is Professor Musa Khurshid from Kuwait. Professor Khurshid. He is there.
I think you are silent, Dr. Musa. Mics.
You can hear me now? Yes. Welcome. You can hear me now, yeah?
Yes, yes.
Okay, so I would like to congratulate Dr. Kahtani for such a great study. This is one of the icon studies that presented the outcomes of endoscopic sleeve gastroplasty, and it's a huge number that is presented in this paper. So it's a cohort looked at 6 months, 12 months, and 18 months. And when we look at the total body weight loss, it's quite comparative to other previous studies that have been presented in the literature. Now, when we look at 18 months results, only about 54 patients have been followed, which is about 85% of the total cohort. And it would be interesting to see the rest of the patients, what happened to them. And I'm sure that Professor Kahtani is working on this issue. Another interesting issue about this paper is the control of type 2 diabetes. And in about 76% of patients with diabetes, they have been cured, all hypertensive, and only 56% of patients with dyslipidemia. From our experience also, the majority of patients present with nausea and abdominal pain, and that is minor, and as has been mentioned in the paper. However, 8 patients presented with severe abdominal pain, of which 3 ESG reversal, 3%, and 0.5% were managed conservatively. So post-operative bleeding also occurred in 7 patients, and only 2 patients has received 2 units of blood, and those are moderate adverse side events from the procedure. It's not severe. Now, in 4 patients, they had pleural effusion and perigastric collection, all underwent percutaneous drainage successfully, and none of those patients required emergency intervention, and there was no mortality in the study. Again, when we look at revisions, 8 for sleeve gastrectomy and 5 for redo ESGs, and the author has addressed the suture durability, the optimal technique, durability of weight loss, and likelihood of revision. So my questions to Professor Al-Qahtani are the following. In your technique, in the methodology, do you do preoperative endoscopy? Because that was not clear in the paper, or do you do it at the time of the procedure? My second question is regarding the technique. You do 4 to 6 bites, and we have noticed that this might not be enough to incorporate the thickness of a stomach wall, and sometimes we have big stomachs. So you might need to do 8 to 9 bites in order to incorporate the greater curvature with the anterior and posterior wall of the stomach. I would like to hear your views in this respect. You used 4 to 6 sutures, a mean of 4 point something. Do you do reinforcement according to the merit trial, or do you don't think that this is necessary in those patients? Again, you leave the fundus of the stomach, and because of the issue of the delayed gastric emptying, and this is something which is different from sleeve gastrectomy, do you still do the same thing, or do you incorporate the fundus in your sutures? Now, again, we look at the hospital stay. You discharge your patients after 6 hours, as you have mentioned. However, almost 21% visited the emergency department, and 8% had 2 to 3 visits, and about 2.4% were readmitted for assessment. My question to you, do you think that we need to keep the patients overnight because of this issue? You have mentioned the optimum weight that you need to operate on those patients. However, in those patients between 27.5 and 30, is it mandatory that they have comorbidity in order to do the procedure, or without comorbidity? I agree with you, our BMIs perform better, and we see better outcome than higher BMI, and it's better to go to bariatric surgery if they are bigger than 35 BMI. Again, another issue regarding the technique, the tightness of cinching, and how does that affect the durability of your suture line? And with that, I conclude my discussion on this issue, and I thank you very much for such a great work, Professor Gahtani.
Thank you so much, Dr. Kharshid. Very nice points. Now, in terms of those who achieve 18 months outcome, they are the people who are eligible at that time. There are people still did not achieve when we reported the paper. However, now we are almost reaching to 3 years outcome. And just to update you in terms of weight loss, it's maintained up to 2.5 years in most of the people, up to 18, let us say, kilogram weight loss average, total weight loss in those who are really in there. So it's up to ranging around 15. Still, most people are maintaining up to almost close to 15 total weight loss. In terms of the pre-op endoscopy, we don't do it. I usually tell the patient that intraoperatively we'll assess, and they are aware of that. We can abort the procedure. If there are contraindication, then we will abort the procedure. If the patient would like to confirm, let us say there is significant reflux or possibility of hiatal hernia, or possibility of ulcers, or possibility of other issues in their stomach, frequent pains or GI symptoms, then we suggest to them, let us do endoscopy, just a screening of operative tools. But we tell them ahead of time that there is a chance that we will abort based, and we do endoscopy as evaluation. In terms of bites, I agree with you, 4 would not be sufficient. So we usually, we go almost 3 to 4 in one row, and then backwards we'll go 3 to 4. So you calculate it almost around 8 bites, between 6 and 8. In terms of number of switchers, yes, the average is 4.8 or so. Total range from 4 to 7. There are people, and we don't reinforce. I don't think it's necessary. I think it will help maybe in durability of the outcome of the switchers in place if we reinforce it. But we take it case by case, and most of the time it's not standard of care that we do. We do 4 around usually, let us say 5 based on the number size of the stomach. We close part of the fundus. For the other question in terms of the fundus, yes, we try to close most of the fundus currently. We notice those in whom we leave big fundus, their weight loss is not optimal, or not as much as those who are really, we tighten their fundus. But we know closing the fundus will take more time. Closing the fundus subject the patient to more risk of, because the fundus is thin, you might capture some tissues around the esophagus, around the fundus, around the stomach. So these complications are possible. We are weighing the benefit of closing the fundus against the risk, and I believe, yes, with those who say presence of fundus will delay gastric emptying, but not to leave big fundus. So it has a lot of the advantage and disadvantage, but I think closing partially the fundus will help in the outcome. In terms of the discharging and coming back to that, we tell the patient, let us say more than 70% will have really pain and significant pain. And some of them will be controlled by oral. But we don't like the patient to have bad experience with the procedure. So we are asking them, please come back to the yard. We call it ambulatory access or ambulatory care access. So they come to this ambulatory care access where they will be treated, rehydrated, given analgesia. So it's not some sort of emergency condition they are coming to. It's, let us say, planned revisit when they need it and they have access to it. BMI, I think we should reposition it. I know now people trying to figure out or find out what is the best or what are the patients who are best for this procedure. Yeah, I know there is because of the prior call, so they maybe the sound is a little bit, but I think when we have repositioning this procedure, initially they were thinking this procedure is for bariatric patient, for 40 BMI, for 35 BMI. This is, in my opinion, is a big failure for the procedure and for the outcome. I think this is a bridge for those who are not candidate for bariatric surgery or those who are really refusing bariatric surgery. So we know in our region also 27.5 BMI is considered obese, like the first degree obesity. But in any way, even if it is still overweight, I think these are the best group to suit around 28, 27.5 onwards for endosleep being reversible, less morbid. Even their outcome in terms of their suffering for the first 1 or 2 weeks with the balloon, the endosleeve and their tolerance of endosleeve is better than the balloon itself in the beginning. And it is more durable and better weight loss. So why not to offer it at this type of BMI? Tightness, I think it's a very good question to ask about. We should not tighten the suture too much when we do the anchor, because that will result in, and we have shown some picture, the anchor itself can penetrate the wall, the needle can penetrate the wall. So we should tighten to a degree that will bring the wall together, but not to the degree that will cut through the wall or penetrate through the wall or result in significant pain. So these are the answer of the questions.
Thank you very much. There's some questions from the audience, if I may, before we get to the next paper. Is there a learning curve for this procedure? How many cases did you do to feel comfortable?
Absolutely, yes. And I think 50 cases, 50 is a good learning curve to make you comfortable of doing the procedure alone. 10 will make you on the road. 50 will make you competent to do it safely and being comfortable and being like somebody who's going to do it without even thinking about each step. That there are 3 learning curves here. There is the learning curve of the endoscope itself. So you should be endoscopist to start with, or learn the endoscope. There is a learning curve of the system itself, the overstitch system, how to load and these things. And there is the learning curve of the anatomy and repositioning of your suture inside the stomach. And I think this is the most critical learning curve inside the stomach, where to put the bite, where to tighten, and where to go backward. These are the learning curve that should be learned before doing or being competent.
Now, this is a restrictive procedure, and we know in bariatric surgery over many years that restrictive procedures may do well for a short period of time and then ultimately not so well. In the 5-year follow-up of the paper you quoted, there was no N for the 5th year. Do you know how many patients were still being followed at 5 years?
I don't have it from that paper, but I can tell you there are significant number up to 3 years, more than even 1,000 patients who exceed 3 years in our study. And this number out of almost close to 2,700, 1,000 of these patients already achieve almost close to the outcome of 2 years and a half and onwards. And these patients are still maintaining good weight loss, more than around 15 total weight loss. Now, I agree, they might not be durable beyond certain period of time, but at least we give them a good time where they are out of this problem. And we know obesity as recurrent, as chronic disease, and we should provide alternative. The good things about this procedure, you can redo it again, you can remove it, you can do sleep after it. So it gives a good outcome, and there still options are still available for every patient.
Okay, and also you listed that 60 patients had comorbid conditions such as high blood pressure, diabetes, etc. The other 940 patients were free of comorbids or just not for the study?
No, most of the people are, we are talking about the 1,000. You know, in these categories, lower BMI, not all of them are really significantly obese, and therefore they don't have significant comorbidities.
All right, and what is the indication for revision of plication to a conventional sleeve?
Two possibilities. One, patient who's not, some patient, they will come to you with 40 BMI. You advise them to go to sleep. They said no, they don't like to go, or even 50 BMI or so. And then they lose, we tell them that the expected weight loss is around 15 to 20 kilogram of their weight. And then they will come a year later or 2 years, they are not satisfied with the weight loss they lost. They are not happy with the weight they reach. Then you offer them to go for sleep. So one, being unsatisfied with the amount of weight loss lost, or regaining their weight. So this is another indication. Some people, yes, they will regain their weight, you will go for revision to sleep.
Have you combined this procedure with medication to see if there was a synergistic effect and have more weight loss? Has that been tried to your knowledge?
Yes, absolutely. Tried in 2 studies. One just recently, randomized study between adding Saxenda to those patients who had ESG after 6 months, or those who don't, and the outcome, yes, if you combined with medication, the outcome is better. So we are going back to multimodal therapies. You offer this procedure, and then you add something to it, and this is an excellent question, and the outcome is really great.
All right, that's terrific. I think for now, we'll switch over to the other paper and have Professor Mohammed Al-Nami discuss it.
You are muted.
Hi, good evening, good afternoon, good morning to everybody all over the globe. Can you hear me well now?
Yes.
Thank you. Thank you, Prof. Sikora. Thank you, organizing committee, for choosing me as a panelist for this interesting paper. And I thank Dr. Athar Al-Ward for his amazing and disruptive idea, which is using the greater curvature as a sleeve gastrectomy. And I would mention the positive remarks about this work. First of all, congratulations for publishing this in a very good journal. Secondly, your rationales are well taken, and they are good reasons to avoid the G junction and to keep the blood supply intact, to avoid less leak rate, which is a very good rationale, really, I found. And also the other rationales that you preserve a better blood supply, and the other reasons. The methodology are excellent, where you have compared greater curvature sleeve versus lesser curvature sleeve, and the sham also group, although they are limited number, but it is acceptable in animal models. Results are really amazing that you did not see much of differences among the two procedures, the lesser curve and the greater curve sleeve in dogs, especially with regard to complications. And also the weight loss was comparable, which is amazing results that I could see. The conclusions are really good, and I hope more can be done on this greater curve work to prove its efficacy in the future. However, there are some questions and things in my mind, as well as others, about the blood supply in the dogs. Are they similar to the blood supply in humans? Because really, I haven't been dealing with dogs for really a while, or even little experience with that. Secondly, the feasibility to do this procedure laparoscopically. As you know, we now do most of our bariatric procedures laparoscopically. So if that is going to be feasible on dogs and even on humans. Also, how can this study be extrapolated to human beings? Is there a link between the dogs and the human beings that you can also mention, so we can really think of doing extra work on dogs in this regard? Also, I wonder if you have commented on the twist of that long greater curve sleeve, whether it is vulnerable to twist or not, as it could be seen on the pictures. As well as not only the twist, is the enlargement. As you know, that part is less muscular, and whether this will gonna be enlarged in the future, or did you notice any enlargement of that? So really, I would like to hear your comments on this, as well as if there are any other questions from my colleagues, they are more than welcome. Dr. Athar.
Can't hear you. Hello? Are you muted? We can't hear you.
Yes.
That's better.
All right. First of all, thanks for the IFSO for inviting me to participate for this very important session. And thanks for the panelists and all of you for your kind attention. Regarding the questions Dr. Muhammad asked me, first of all, the blood supply, is it comparable? Yes, it's quite similar between dogs and humans. The only difference mainly is the orientation of the stomach. The dog's stomach has like a Y-shaped orientation due to the posture of the animal. It's not straight laying in the abdomen like a human. And another thing, the electrical conductivity, the way the conducting electricity around the dog's stomach are quite similar to human too. So it's a good animal model to do such a surgery. The other thing is the twist, I guess. You commented about a twist in the pouch. Well, this pouch has probably most of the gastric fixation still in place. We have connection to the left loop of the liver through the pars condenser, the proximal part of pars condenser. We have the phrenogastric ligament, phrenosophageal ligament intact. We have the splenogastric ligament intact, and we have all the greater curvature attached to the greater omentum. With the weight of the greater omentum and the transverse loaded transverse colon, can maintain this like gentle C curve sleeve intact without any twisting. We haven't done really long-term follow-up, and we haven't done yet many human cases to comment about this case, but in theory, it should be having a good luminal patency. due to the gastric fixation all around. The other comment was regarding if this can be extrapolated to humans. Of course, the biological mechanisms between different species are not the same, are not consistent between different species. So we cannot really think that anything can be done in human can be clinically relevant. But this study was focusing mainly on the technical feasibility. Would this pouch be supplied, well supplied with blood? Would it be patent with motility? And will the dogs lose weight? We did not venture about hormonal and other things like gastric emptying and other things, which I don't think will be quite comparable in humans, but it can be studied also. Other thing, is it possible to be done laparoscopic? Unfortunately, I couldn't see my pre-recorded presentation due to the interruption that happened in this session, but the last slide we have mentioned that back in the time we did that study, we believed that this can be done laparoscopic, but now we know that because we have done human cases. And the first one of them had more than 1 year follow-up now, and it lost around 93.8% of its success rate, with the food tolerance score reaching around 26, no problems, no nutrition deficiencies, it's doing fine, but still we don't have enough number to give results or say something that can be relevant on a scale. But hopefully near future we'll do that. I hope that can cover your questions or any other remarks from other panelists.
I think that I see that most of the questions relate to the need to measure the small bowel. Would you like to expand on that?
I'm sorry, I didn't hear the whole question. The internet was.
There are several questions related to measuring the total length of the small bowel.
In my procedure, in our procedure?
Yes.
It's a restrictive procedure. We did not do any bypassing. It's a restrictive procedure on the stomach. We did not measure the small intestine length in this procedure. So no, we didn't do any total bowel length measuring in this case for this procedure, which is a restrictive procedure limited to the stomach. But the point in this procedure that we preserve the gastric pacemaker area, so we expect that the gastric emptying will be better and we will have shorter transit time, small intestine transit time, which can add as a malabsorptive procedure too.
Someone from the audience asked about ghrelin. Have you checked ghrelin levels in the 2 versions of sleeve?
No, we did not. As we mentioned earlier, that not all the biological mechanisms in dogs and humans will measure, but we tend to do that in the future.
And I'm sorry, I lost contact after I asked the question, so I don't know whether you even heard the question I asked you, but the greater curvature of the stomach dilates. Are you concerned that it'll dilate on your sleeve over time?
There is a possibility that it would dilate, but as well known now that more than 50% of standard sleeve dilate after a year or two, and this dilation to increase daily caloric intake or failure to lose weight. And it's well known also that the smaller the sleeve at baseline, the more dilation that could happen. And mainly the weight loss is not limited to the restrictive nature of the procedure. It's more to the neurohormonal and changes that it can afford.
All right, I'm looking to see if there are any more questions from the audience.
I don't see more questions, Scott, so if that's okay with you, we can go ahead with the next part.
Exactly what I was thinking.
All right.
So I want to thank the speakers. I want to thank the discussants for this very interesting session. And after a short break, I believe we'll have a vote on the best paper.
Well, I think we're not going to have a break, Scott.
Oh, okay.
We'll just go ahead.
And as you can see, the winner is Dr. Al-Qahtani's paper with 42% of the votes, followed by Dr. Nabil's paper with 25%, Dr. Elwart's paper with 21%, and Dr. Abelbaki's paper with 12%. So congratulations, gentlemen.
Congratulations, all of you.
Thank you.
I think that's the end of the session. I once again want to thank the audience for attending, the speakers for speaking, my co-chair, Professor Herrera, for doing this with me, and for the leaders of the NEMIC Society for inviting me. Thank you very much. Wish you best for the rest of the meeting.
It has been a pleasure. Thank you very much.
Thank you.
Thank you.